Welcome to the 8th episode of our iSense Q&A series. I am Erin Manning, the Communications Manager for the UCL-led iSense project, which is an EPSRC-funded interdisciplinary research collaboration focused on developing tools and technologies to track, test, and treat infectious diseases. This Q&A series is a chance to speak to and learn from experts working in fields related to infectious disease surveillance, testing, treatment, and beyond. Today we have the absolute pleasure of speaking to Professor Claudia Estcourt from Glasgow Caledonian University, Dr. Harpreet Sood from the NHS, and Savannah Fishel from National Voices on the topic patient pathways.
Hello everyone, I'm Claudia Estcourt. I'm a clinical academic and Professor of Sexual Health and HIV in Glasgow, and also I board at UCL from time to time. My big research interests are in digital sexual health, particularly looking at online automated clinical care pathways with inbuilt clinical decision-making algorithms. Across that is a very keen focus on inequalities and trying to narrow them rather than actually make them bigger by doing this. And then secondly, relevant to today, my other major interest is in looking at contact tracing, mostly for STIs and HIV, but looking at that in the guise of a complex intervention to reduce transmission.
Thanks very much, Claudia. Harpreet, would you like to introduce yourself?
Thank you. Good afternoon, and great to be here and see colleagues. My name is Harpreet. I'm a primary care GP in London, and I also sit on the board of Health Education England, which is an organisation responsible for the training and development of the NHS workforce. I used to be the former Deputy Chief Clinical Information Officer at NHS England, bring the worlds of clinical together with digital health and thinking about how we are redesigning pathways, but also thinking about the transformation agenda. And without a shadow of doubt, the last 12 to 15 months has obviously accelerated that, but I think we're also in a place where actually we do need to think about the sustainability of this and what this means for patient care, but also how this may change the way we provide clinical care. So that's where my work still continues, and I'm hoping to share some of those insights with you all today and have a discussion on that.
Thanks very much, Harpreet. Thanks for joining us. Savannah, would you like to go?
Sure. Hi everyone, yeah, thanks for having me as well. So I'm Savannah, I'm from National Voices, and for anyone who doesn't know, National Voices is a coalition of about 170 plus member charities, and our mission is to further personalise and democratise health and care, and absolutely central to what we're trying to do as a coalition is, as like Claudia was saying, it's about closing the gap of health outcomes and closing that inequalities gap. And obviously the last year, there's been an absolutely seismic shift in how health and care services can operate. And so what we've been trying to do is we've been trying to do research to document the experiences of people impacted by that change, especially of people who already are on the wrong side of the inverse care law. And so we've been trying to use this research to creatively think about how health and care services can engage communities, can engage more people, but also we've been trying to use our research and people's voices to advise service providers on how to think inclusion first. And I was just saying that this morning, we actually released our big piece of work that we've been working on for about 8 months, which I'll share a link to in the chat, but that is sort of our key findings over the past 8 months around digital inclusion and exclusion. So yeah, really excited for today.
Very much, Savannah. Please do share that link in the chat for everyone, and congratulations for launching that. Thank you all for those introductions and for joining us today. I have a really overarching question to ask first, and that is, how have patient pathways changed in the last few years? Maybe Harpreet, would you like to start with this one?
Thanks, Erin. Sorry, I think you cracked up a bit. Was it the patient pathways changing in the last few months or few years?
Few years, and then I guess a focus on the last year because a lot more has changed.
Yeah, absolutely. Well, look, I think if I start with like the last few months and then go backwards in some ways, I think, you know, what has been clear, if I look at the trends and where we are seeing the benefits, two clear trends kind of really stand out at the moment. One is that there's been an increasing acceptance of the use of technology in healthcare, which I think has been very positive. And I think the second one being that there's been an increased perceived usefulness of what technology can do in healthcare, and particularly from a GP's perspective, but also to some extent from a hospital perspective. And I think that's really fundamentally changed the way now we think about how we want to interact with our patients. And in some ways, starting to see them with that consumer lens on as well. Now, the challenge we have is that this certainly doesn't work for everyone. And I think that needs to be captured. And let me give you an example. When the pandemic started around March time last year, it started before that, but when we started seeing the seriousness of it in this country, I said to one of my patients, you know, isn't it great that now you can use your smartphone to interact with me virtually? And he said, you know what, Doc, not really, because I've got limited data. I have no Wi-Fi, and I'd rather use that data to speak to my family in Bangladesh. And I think it made me realize that actually when we think about access and inclusivity, we still got a bit of thinking to do and what that means in terms of how we are really redesigning pathway. What we've seen in general practice, which to some extent I think will stay because I think it has a benefit both for patients and clinicians, is that this concept of total triage first, which is that actually through a telephone or through an e-consult platform that we've been using in certain practices, you can quickly triage and see whether the individual needs to be seen face-to-face or can be dealt online. And I think that is potentially quite game-changing because for many patients, it provides access, potentially better access, it provides better experience potentially, but it also provides better convenience. And so on that basis, there still needs to be evidence to generate and to demonstrate that that is the case, but that's the hypothesis at this point. But the challenge we have then is that what hasn't changed is everything else along that pathway. So how patients are getting blood tests or how they're going about and getting diagnostics. You know, I think there needs to be a lot further work into say, well, if we're really serious about change the whole pathway, it needs to be done end to end. And I think we've got a bit more work to do on that. Other elements of the patient pathway that have now considerably changed, for example, is e-prescribing. So before, you know, and many of you may have done this, you would have to call up your GP who would then sign your prescription, then you go and pick up your prescription from the GP practice and then take it to the pharmacy. Now what we're doing is actually patients order online through the NHS app or through the by calling us, and we then electronically send the prescription to the nearest pharmacy and the patient either goes and picks it up or gets it delivered home. So that for me is a good example of patient pathways changing. But the opportunity lies actually more than that, is to say, how can we think about it from all the way from primary care to secondary care as well? And that requires a fundamental shift, which we haven't quite figured out. And those are the pathways that need to be looked at. And the work centrally that's being done by NHSX and NHS England in particular are now starting to look at certain clinical disease areas to develop use cases, such as managing blood pressure, looking at ophthalmology, but also, for example, some orthopedic pathways where actually these use cases might demonstrate what does a wholesale transformation look like from a patient pathway perspective. So I think it's a watch this space kind of moment, but at the same time an opportunity both for patients but also for clinicians to really redesign and make sure it benefits everyone.
Thanks very much, Harpreet. You broke up a little bit at the end. I don't know if it was me or... Thank you very much. Claudia, do you have anything you'd like to add to that?
Yeah, I think we have seen a shift to remote and self-managed care. And controversially, I'm going to say that a lot of that's being coercive and has happened in the absence of patient choice or patient autonomy. So in some respects, I think it's fantastic that for some people, certain elements and certainly perhaps their costs of achieving the care that they perceive that they need may have reduced. But I also think that we have disenfranchised a lot of people, and in specialties which serve those who are disproportionately vulnerable in society, who are what I call pull specialties. They are where we open our doors and we are really trying to drum up our client base. We're urging people to come in. We know we can do a lot for them. Health may not be the top of their agenda because they've not got a house to live in or not got any money to feed the kids. Doing that remotely might work for some people some of the time, but won't work for everybody all of the time. And it's been a very blunt tool out of necessity during the pandemic. And I think that we really need to be urging choice coming back into the equation. I think as well, governmental rhetoric on this has assumed that everybody is very autonomous, very health literate, and very digitally literate, and that the health care that they need is transactional. I want to order something on Amazon. I know what I want. I'm going to order it, so I will get it. I'm sure Harpreet would say the same. When patients come and see me, what they think they need may not be what I think they need to sort out their health problems, and I may diagnose a couple more health problems serendipitously along the way. So although we have seen a leap forwards, I think this has happened out of necessity. I think it's not happened with co-design. It's not happened in a way that's been well evaluated to date. And I think we need to take stock at this point. In my field, it's been largely telephone. It hasn't been a predominantly jump online. So I think when we talk about remote, we need to be very clear what we are talking about. Remote could be telephone, it could be online, could be a mixture of the two. And then if we get time, I'd love to come back to the concept of triaging people, because there's increasing noise that for some people, they find it intrusive. They are unable to list all of their conditions. They don't understand all of their conditions. And again, it may be just that systems have not been co-designed, that they've come in out of necessity. And for some people, that creates barriers. So to sum it up, a lot has changed. Some people have really welcomed those changes. There's a huge more amount that we can do, but we've got to do it with people, and we've got to be acutely aware of those health inequalities, which have absolutely, without question, widened what we can now do to narrow them as we leap forward even more ambitiously.
Thanks very much, Claudia. And Savannah, would you like to add anything there?
Yeah, sure. There was a lot there, and I agree with so much you both have just said. So what I'd say, so in answer to how the pathways changed, I'd say in many ways, there's more options than ever before in terms of how patients can engage in care, apps, phone, letters, triage forms that have been mentioned. But what I would say is, I think off the back of what Claudia was saying, that does not transfer into choice for the individuals, because it's about meeting complex and diverse access requirements, and providing all of these options, all of these ways, is not the same as providing informed and supported choice that meets people's access requirements. So I will say, I think a huge change has been that in some ways positively, inequality, a real spotlight has been shone on inequality. And I think that government rhetoric has changed, and it's much more on centre stage, and people are much more aware of the inequalities that have been stark for a long time and widening for a long time. The Marmot Review, then the Marmot Review 10 years on, is a perfect way of showing the progress that's not been made in those areas. And obviously, digital exclusion has shot to the top of the agenda in the past year or so, as more patients have been locked out of using the NHS, essentially because of that need to go through what we're kind of referring to at the moment as the digital front door. We just talked briefly about triaging patients, and I think there have been a lot of changes that are more convenient for the health and care service, such as triaging patients, self-management, And the problem is that, as Claudia was saying, that works well for a lot of people, but for communities which, I don't like the phrase hard to reach, instead of using that, communities that are easily ignored, for example, are then excluded further by changes in terms of self-management and triage often. So what is really crucial is that that co-production, like Claudia was saying, is absolutely central, and that people who are from disadvantaged communities, from often easily ignored communities, are thought of all the way through these changes, and that often hasn't been happening, which has resulted in these changes, which are often supposed to make things more convenient, actually instead exacerbating inequity further, because it leaves people out. It works well for some people, but the people it leaves out are already at risk of being excluded. Essentially, one size clearly does not fit all. I'd say another big change is, or maybe getting sort of just worse, is tech optimization bias. The idea that there are a lot of technical changes, there are a lot of digital services and changes coming in, and new ideas and innovations and interventions, which is often great, but when they're not co-produced, they end up making the situation worse. One other thing is just as well, Claudia mentioned transactional relationships and the idea that healthcare is transactional, and the issues with that. I think one huge learning that we at National Voices have a huge insight, which we've really just heard from people, is that people feel that they're in a relationship with the system. So over the past year, waiting times have become worse than ever. And people understand often that they have to wait a while. People understand that the NHS is under more pressure than ever. And from what we've heard, people are really empathetic to this and really empathetic to healthcare workers. But what people feel is that they are in a relationship with the system, and they don't want to be ignored. They don't want to not know what's going on. So I think communication has become more important than ever. And clearly people do not feel that their healthcare is transactional. It's relational instead. And one just last thing as well is, I think an innovative culture has really grown and blossomed over this last year. I just wanted to end on like a more positive point. I think what NHSX has been doing, but hugely the voluntary sector, there has been a culture of bravery, boldness, and also evidence that co-design and co-production can happen really, really fast. And it can happen from the beginning, even when urgent changes are needed.
Brilliant, thanks so much. It's so interesting to hear that, Savannah. I forgot to mention at the beginning, Harpreet does have to leave at 2, so if anyone has any questions for him, please write them in the chat. I have one audience question which builds on what we've just been talking about, and that is, how can digital healthcare pathways be designed to ensure accessibility for all users, thinking about things like visual impairment, language, and digital literacy? You mentioned co-production. Would you like to expand on this? Maybe Harpreet, because you have to pop off. Would you like to start?
Yeah, absolutely. You can hear me okay? Yeah, perfect. No, so look, I think it's really important to frame the question here, which is that we shouldn't get too hung up on the technology aspect of things. I think this is more about understanding that technology is an enabler. And I think I think it is a positive step, but and acknowledging everyone saying, is that the fact that it's being recognized that it is a potential and that it needs to be part of the core operating model, I think is a useful starting point. Now, by no means does that mean that it works for everyone, and I totally appreciate that, because I've seen many patients that struggle with technology, and I wouldn't want to interact in that way. But it does help also a good proportion of people, where we can actually provide that experience for them and think about what they can do differently, which means that we may get more time with people and patients that need more time in clinic, for example. I think from the part around inclusivity and how can we include others in terms of literacy, accessibility, visual impairment, and so on and so forth, I think co-production is absolutely right, but also understanding, well, what is a problem we're trying to solve here, right? Is the problem around access? Well, absolutely, that might well be the case. Is it around providing a different experience? Possibly. is it around convenience? And if that is the case, then what tools do we have in place today, and opportunities do we have in place today that allow us to do that? And I think, honestly speaking, I'm not quite sure we've ever really dug deep into this and thought about this from an end to end, in that what does the future of primary care actually look like? If that's the angle we're looking at, what does the future of the hospital look like? And if we now think about the potential reforms that have been proposed with integrated care systems and bringing health and social care together, the voluntary sector together, to develop new ways of organizing the health system, maybe this is a really unique opportunity for us to think about all the different aspects of it. I mean, just as an example, right, so many times when I've worked, and I still continue to see this, is that if I wanted to get information about a patient that's seen someone in the mental health setting or a social care setting, or other settings outside of the NHS, it's very difficult for me to get that information real time. That data is there, but it's just not accessible. I mean, and that is clearly not benefiting the individual, but also making sure that I'm not providing necessarily the best care. So, are these opportunities now for us to think more radically in terms of how can we join up a lot of this and bring this all together? And the patient's voice absolutely is critical, as well as understanding people from different backgrounds, different ethnicities, and thinking about it from both a physical accessibility, but also language and cultural. And if I again draw a parallel to the vaccine program rollout, I think the reason why it's been a success in the whole is that because we've engaged people at the community level with many faith leaders and community leaders, but we've also brought in the idea of accessibility, like I said, in terms of language and physically, but also thinking about language, culture, beliefs, and how we can develop a health system that encompasses all that. I still think we've got a long way to go on that, but this is a starting point for us to capture that and bring that.
Thanks very much, Harpreet. I think you cut off slightly at the end there, but Savannah, I'll hand over to you if you want to add to that.
Thanks. Yeah, just briefly, I agree, and I think it's useful to draw parallels with the rollout of the vaccine program for a lot of system changes. I mean, it's obviously been successful in many ways, and I think a lot of that is the fact that the co-production, the building of trusted relationships, the going to communities instead of consistently expecting communities to come to the service. I think that's really important. But in terms of some sort of tools to put inclusion, really put inclusion at the center, I think just thinking inclusion first, not digital first, is a guiding principle, which should be absolutely central to any innovations, interventions, or changes, because this is going to allow service designers and providers to avoid bias toward tech, but also to people who communicate a certain way, to people who live in a certain area, to people of a certain gender or race. And this is how we prevent exacerbating inequalities when changes are rolled out at speed, thinking inclusion first, not digital first. That'd be the first thing. Another is co-design, which we've obviously talked a lot about, and I've mentioned, because a sort of risk is thinking of co-design as a nice to have. It's not, it's a necessity from the beginning, because if something is not co-designed, it saves resources in the end, because if something is not co-designed with communities it intends to serve, the risk is much greater of it failing to serve those communities, and therefore resources are wasted, and it ends up not actually, the service change ends up not actually doing what it sets out to do. So co-design, and I think Harpreet said this about being aware that tech should be sort of people-led. So yeah, innovation or system changes should be people-led, not tech-led, and I think that's a really good sort of guiding principle for that co-design as well. Another thing I would say is supporting staff along that journey as well is so important. One, because staff are the ones who are, especially administrative staff, are the ones who are communicating changes to patients. And I think that's absolutely central. But also in this new digitized world, the assumptions cannot be made about staff's experience or confidence levels or privacy at home or anything like that. So I think that's really important, taking staff on the journey and designing staff training and consistent support throughout as well. One more thing is just remembering that health is wider than healthcare, because I think over the past year, a lot of the voluntary, so in the report I shared, we've looked, it sort of has an innovation catalogue of what voluntary and community organisations have done and successes as they've desperately tried to engage their beneficiaries in new ways. And in a lot of times, the success has been when that boundary between formal and informal care has sort of been blurred, and patients or beneficiaries have been engaged through social means as well, and through building trusted relationships and making sure that those are solid. And then that's when sort of more traditional healthcare engagement can take place. So it's about understanding, I think, that the centrality of trusted relationships, and like I said at the beginning, going to communities and understand and being led by people who understand the nuances of their own community. I think that's really central. So yeah, the main thing is what it comes down to, I think, is offering supported choice, like Claudia said right at the beginning, and personalization, because it's communities and people are diverse and have different requirements, and assumptions made just can end up exacerbating inequality.
Thanks very much. Really important point, Savannah. Harpreet, you got your hand up. Would you like to?
Yeah, just quickly respond to that, if I may. I think one of the real opportunities we have at the moment is to really paint the picture on what good looks like. And I don't think we quite know at the moment, actually. And I think this is the time to be thinking about it. What is our aspiration in this space? Where do we want to get to? Because I think, you know, and I've been part of this as well, we talk about digital health, we talk about technology, we talk about other elements of it. But actually, where is it all going, and what does it mean in terms of how that will change the care delivery, but also, like Savannah said, bring all this together? And I'm not quite sure that we have a clear idea of what good looks like. And I think there's a real opportunity to do something about that.
Erin, I think you're on mute, but I was just wondering if I could just really say really quickly, I know Claudia, sorry, I'm sure you want to come in. I just really wanted to say in response to that, I do agree, but I think sharing progressive practice is a really good way to get there. And there have been so many examples of, I think we can't make too many assumptions about where we want to go, because there are so many examples of when community-led interventions or interventions have brought something sort of unexpected over the past year, and sharing that sort of progressive practice and those successes, I think, is a really important starting point to seeing where we can go next and what's worked. Sorry, Claudia.
Thanks very much, Savannah. I'm just going to thank Harpreet, because it's gone on to, and I know you have to pop off, but thanks so much for joining us and adding to the discussion. It's been really interesting. Take care.
Thank you all. Bye-bye.
Thanks. And over to you, Claudia.
Just like to come in. I think we could be really ambitious, and much more ambitious in terms of the elements of care or particular care pathways, which, for those of you who don't talk health service research language, are the series of steps that everyone goes through to achieve a particular health outcome. And we've all been on one, whether we know we have or not. So if I have an STI, or I think I might have an STI, it'd be a really good idea for me to get some tests done, get the results of those tests, subsequently get the treatment I need, and then for my sex partners to also get tested and treated. That would be a care pathway. It sounds very easy. It's complicated. There are lots of actors, both myself, my sex partners, the healthcare professionals, the laboratories, and the doctors who give me the treatment, or the nurses who give me the treatment. Up until this point, we have been really unambitious in what is delivered online. We need to be able to deliver a whole care pathway like that online, so that somebody could achieve that face-to-face if they want to, but could also achieve that end-to-end online. We know from the research that my team and my group and my collaborators and co-investigators have done, and others, that for those people who would like that conceptually, they want an end-to-end service, they want to be supported, they want to be able to speak to a specialist if they are concerned, if they fall off the pathway, if they can't remember the name they logged in on because it was a different one. And they may want to use that at some time in the year, but at other times in the year when they might have had a really bad date, they might be really worried about a dodgy partner, or there's lots of other things going on that's stressing their mental health. They may well want to come and see me or one of the other doctors or nurses in clinic. And that's because we're humans. So what we've not really thought about is the fluctuance in people's desire and ability to engage in the online healthcare environment and how that changes. So we're not neatly labelled. Somebody who has a physical disability may at some time be absolutely willing and able to engage in a particular modality of care, but at other times not at all, because they might have had an exacerbation of their condition. Within my field, the emotional content is really important, and some work that we've been doing, looking at how gay and bisexual men who have sex with men feel about doing their own checkup tests at home, can vary quite considerably with the emotional context. So this is becoming really multi-layered. But if we start with the idea of choice, we start with the idea of being much more ambitious, but we also retain within that a very keen sight on the people who want to use digital some of the time, some of the people who want to use it all of the time, but we might think we'd like to see them face to face. And those people for whom it will never be safe or appropriate to use it for much of the time. I think that's a really good starting point. And just my last point on this, to sound very trad and very scientific, is to look at every bit of the care we deliver online as a complex intervention. And those of you who like reading Medical Research Council guidance on this, there are lots of steps involved. Tech likes to leap forward. Rigor, co-design can't leap forward to the same speed, or it can, but the product that you get does not stand the test of time. So at the risk of sounding like a bit of a slow coach in here, the evaluative framework and the co-design has to happen in parallel. Otherwise, that technology will not be usable, useful, or used.
Thanks very much, Claudia. Savannah, yeah, you want to add to that, please?
Yeah, I do want to add to that. I completely agree with everything Claudia's saying, and I think she says it so eloquently. And I think what Claudia was saying about people are human beings and people have diverse needs, but also different needs from time to time, or condition or period of mental health or period of mental ill health. It's really important. And I think remembering that is how changes to healthcare systems are made sustainable. And I think it really is about sustainability. And so what I think we've found hugely over the past year from our research is that digital exclusion is so complicated. We hear so often this phrase, the digital divide, which I find quite difficult because it's really not a binary divide. And people are at risk of exclusion for so many different ways, but also at different periods of time. And so I prefer to think of it sort of as a chain of inclusion, and on there would be trust, confidence, resources, skills, the specific healthcare problem or condition you have at the time, whether that is something that can be easily transferred via a photo or a phone call. So if any parts of this chain break, which may be even for people who are competent digitally, maybe because of a privacy issue or whatever it might be, then that person is then at risk of being excluded if the only options of accessing care are digital. So yeah, I think it's remembering, as Claudia said, that people are human beings, and from time to time, their needs and requirements and preferences will change. I think it's absolutely essential to making sure that any changes are sustainable.
Brilliant, thanks so much, Savannah. I wanted to touch on a bit of how we engage with policy and how policy is changing with technology. So how can researchers better work with healthcare and policymakers to ensure their work meets their needs and also has the widest influence? Maybe Claudia, could you go?
Oh, that's such a good question. I seem to go around trying to make lots of friends in lots of different places and saying the same thing all over again until I'm sure people get completely sick of us. We've taken an approach, we've been fortunate enough to have a 5-year programme of research, which is NIHR funded, which means that there's a very keen focus on translation of research outputs into real world. And as part of that, that is focusing on how we can deliver complex clinical care for STI management online. And as part of that, we've got a stream running through it, which directly involves policymakers from the start. And we have included some key people within our co-investigator group. Now, I'm aware that there'll be academics here going, yeah, good idea, good idea. There will be people from tech going, my God, 5 years, what planet is this woman on? So there will be a compromise somewhere in the middle. But again, you've got to show that what you're doing is safe. I've already mentioned that I think the stuff that's happening online really lacks ambition in many respects. We need to be pushing forwards. That also touches on the regulatory framework. And as many of you will know, the regulation within a lot of health is fit for a paper age. This is the deeply unsexy bit that politicians don't tend to roll their sleeves up about because it doesn't really win many votes. But there's a lot that we can only do within a research context where somebody has given informed consent for the intervention that they're about to be offered, which really, it would take half a day, especially with online voting in the House of Commons, to have a few health bills just getting the regulations fit for purpose. It's not that we're trying to do anything that is scary or inappropriate, it's just that they were meant for a paper age, so the wording doesn't even fit. And some of the regulations that we looked at in one of my close colleagues, Dr. Joe Gibbs' PhDs, you could see where cut and paste jobs had happened. So the current regulations actually didn't make any sense at all because people had tried to update them and then things fell apart. So I think it's got to be showing the safety of what we do, showing the ambition, showing the rigor, showing how the vote winning bit is that it's co-design, involving people from the start. And if there are people listening who have experience that they could certainly share with us on how you get some of the regulatory changes made. And these aren't for big scary interventions, these are for what the general public would feel quite pedestrian. We would be delighted to get some input and advice as well.
Thanks very much, Claudia. Savannah, would you like to add to that?
Yeah, so just quickly on the idea of encouraging policymakers to listen to changes which are absolutely essential but potentially unsexy and don't make headlines. I think that really it's a difficult job, but it's an important job of researchers, and that's exactly what we're trying to do with our research. And one piece of work that actually is coming out hopefully in the next couple of months that we've done with the King's Fund is about NHS administration, and it's absolutely central to quality care, working with administrative staff, looking at systems, especially in the new digitized age, but it's something that gets absolutely minimal attention. And so as researchers are trying to make that case, especially probably using arguments around saving resources, which improving these administrative systems will, and therefore it will improve health outcomes as well. So when it comes to admin, obviously good admin doesn't equal quality care, but bad admin does exclude people from the healthcare system altogether. So that's hopefully coming out soon. And so just about sort of closing the insight, evidence, policy, practice circle, it's obviously quite difficult, but I think more than anything, it requires proper engagement. It's about listening to communities and ensuring, as researchers as well, that their needs and interests are amplified in an accessible way, and therefore that their needs are safeguarded as tech changes. And we've talked about co-production, but it does come back to engaging people from the beginning, actively listening, but also, and that's not a linear process. So ensuring that there are feedback mechanisms throughout when services are changing, actively going out to communities, finding feedback, listening to it and acting on it, and constantly updating systems, conducting that rapid insight work and really learning from it. And that is what we're trying to do as researchers. It's obviously not easy, but central to getting ourselves heard as researchers is building partnerships. And I think a lot of really good care and really good innovations happen when there's that partnership between statutory sector and voluntary sector and policymakers. So yeah, collaboration and long-term trusted partnerships are going to be really central.
Thanks very much, Savannah. I want to move on from that to track and trace, and for both COVID and other infectious diseases. My question is, this year is the first time many of us would have become aware of track and trace and how it works, and many of us would have used the NHS track and trace app. What do you think is the future of track and trace? How important is technology in this process? And I have a question from the audience, which I'm going to weave into this, which is, what can we apply in terms of digital pathways and the scale up of test and trace to other infectious diseases? Sorry, that was a long one.
Is it okay if I make a start here? I love talking about this because as the big failing of track and trace was that it wasn't seen as a complex intervention. And this goes back full circle to what Savannah and I have been discussing right from the start. So if you develop a beautiful app and give it to people, and the app tells you what to do, some people will love it. Some people will show that beautiful icon to their friends. Some people will think it is the best new decoration on the Christmas tree, and they will do exactly what the app tells them to do. For some people, that's easy. They might live in a beautiful mansion in Wiltshire with a tennis court with a swimming pool. Ocado can come every day if they want to. So self-isolation isn't too bad. It's a bit of a pain, but you get by. You can lose yourself. You can use a child if you want because your house is so big. If you give that to somebody who's on top of a tower block, who has perhaps a multi-generational household, there's no lift, you're stuck in 2 rooms, the thought of the major breadwinner who's an Uber driver not being able to go out and earn some money driving a cab would mean that being told that the whole family needs to self-isolate for 14 days and preferably put the Uber driver dad who has the infection in a separate room is totally impossible. So we've already demonstrated that there's a massive divide across the population in not only people's intent to follow, perhaps to follow the self-isolation guidance, but also people's ability to do so and the hardship they will feel as a result. So I think what's important to say is that the app undoubtedly for some people has, the proximity indicator app has shown some benefit. There'll be some people who found it dramatically helpful, some people who were able and willing to follow the directions in the app. But as a scientific construct, it was developed at speed, out of necessity. The barriers and facilitators were perhaps not fully researched. The usability of it in diverse populations, and also the implications of the information, which was entirely negative for anybody, even if you're living in a mansion, that you have to be in self-isolation for 14 days, really didn't appear to be appreciated. So for me, the future of track and trace goes beyond an app. Track and trace is all about preventing transmission. It's about infectious disease epidemiology. It's got to be combined with testing, which could happen very nicely as part of an integrated system with postal self-sampling, with results available, but with choices to get tested that are easily accessible. But it's got to be as part of a complex system where all of the components work properly. I think personally that also needs to involve much greater support for people to self-isolate where they can or to reduce transmission in the household, perhaps support for people taking them out of the household, and financial support almost certainly for those for whom any drop in income or earnings would be catastrophic to their own well-being and that of their family. So it's got to be seen as a complex intervention. It's got to span not just health, again, relating to what Savannah said, it's social support, it's support for the family, for individuals, for communities, within a wider set of measures that don't just revolve around the simplistic option of a proximity indicator app where people were bound to download it, were bound to use it, and were absolutely bound to self-isolate as a result of it.
Absolutely, really important. Thanks so much for sharing, Claudia. We hit 2:15, so I just want to ask a quick summary question. If there's one thing that you've taken away from the last year, or one thing that we haven't mentioned in this Q&A that you'd like to share with everyone, what would that be? Savannah, maybe you would like to go?
One thing, okay. I would say one size does not fit all, and the only way you can know what does fit people is to ask and listen. And just one more thing, this is kind of 1.5 things, is I would say trust, off the back of what Claudia was just saying as well. So health, we can't just think of health as clinical, and trust varies for good reasons, and people who've been caught up in the fallout of the Windrush scandal, or who are constantly being stopped and searched by the police, will be far less likely to trust the app or whatever the new intervention may be. So we really need to work on that. We need to work upstream if we want all communities to benefit from changes, and working with and engaging the voluntary and community sector is absolutely central to that.
Thanks very much. And Claudia?
Okay, I've got 4 very quick things, and they overlap with Savannah's. Provide people choice at all times. We need to be ambitious in what we are trying to do. We need to co-produce and be inclusive, and we have to evaluate at every possible stage.
Really important. Thank you so much for everything you've shared with us today, and for joining us for these 45 minutes. It's been really interesting to hear both your perspectives over the last year and across your research. So thank you very much for being generous and sharing all the links in the chat as well. I'll put those on our website so people can link through to them. And as I mentioned, this is recorded and will be on the iSense website. So please do feel free to share. Thank you so much for joining us today.
Thanks for sharing, Erin.
Thanks, Erin. Lovely to meet you, Savannah.